Hello everyone. Welcome to the session of Dermatology Previous Year MCQs INI-CET 2022. Now, once or twice in a week, we are starting with a series where I will be discussing the PYQs of different exams. I request all my students to kindly follow us. This is a YouTube channel named Dermatology Pulse by Dr. Cheshta, which is specifically made for dermatology revisions, MCQs, concept clearings. I want everyone to please press the bell icon and subscribe to this channel, that is Dermatology Pulse by Dr. Cheshta. Now, there are a lot of students who know me, but for those who are joining for the first time, I'm Dr. Cheshta Agarwal, your NEET PG educator. I have around 10 years of teaching experience in the field of dermatology. I myself scored All India rank 261 in my NEET PG entrance examination. Meanwhile, we will be revising about the dermatology, but I will also help you guide whatever tricks, tips I have used to get a good rank like 261. And I will also help you out in your revisions, last moment practice, MCQs, etc. So please follow me on this YouTube channel, that is Dermatology Pearls by Dr. Cheshta. Now let us start with the questions which we get recently or which we got recently in INI-CET 2022. The first question which was there from dermatology is that there was a pregnant lady on leprosy treatment who presented with type 2 lepra reaction. What will be the line of management? Now, one thing I want to tell all my students that a chapter or a topic which is known as leprosy, it is a very, very important topic. Specifically, if I talk about the NEET and INI-CET. For these two exams, I'm seeing that one question is for sure. So try to revise this chapter in detail. You can also follow this YouTube channel to have a little bit more crystal clear appearance or crystal clear concept of the leprosy. Now, in this question, the question is from the lepra reaction. So before telling you the answer, let us discuss what exactly is this lepra reaction. So we need a plain paper for that. Amazing. Now, what happens? Leprosy, which is a bacterial condition, whenever you start them, the patients on treatment, we give multi-drug therapy to the leprosy patients, right? And what is the content of the multi-drug therapy? It includes rifampicin, it includes clofazimine, and it includes Depson. Whenever you start the MDT for the leprosy patient, there is sudden killing of Mycobacterium leprae. And this sudden killing of Mycobacterium leprae generates a lot of inflammation on the skin or in the body. This inflammatory reactions, they can be of two type. One is type 1 and another is type 2. So we have type 1 and we have type 2. Type 1, it is mainly seen in the borderline cases. Borderline means borderline tuberculoid and borderline lepromatous. While type 2 lepra reaction is mainly in the lepromatous group of leprosy. That is BL and LL, mainly the lepromatous group of leprosy. Now, you all know that Mycobacterium leprae can present in a varied spectrum. It can have a localized disease, which we classify under the tuberculoid leprosy, and it can have a diffuse variety, which is known as lepromatous leprosy. The borderline is a comparatively localized compared to that of lepromatous, and it is said that the reason why the disease is widespread or it is localized, it is because of the immunity. If the immunity is good, the disease is localized. And if there is poor cell mediated immunity, the disease becomes widespread. In borderline group, obviously the CMI is good compared to that of lepromatous, where the CMI is very, very poor. You all know that for a intracellular organism, you always generate a cell mediated immunity, which is type 4 hypersensitivity reaction. But in the patients of lepromatous leprosy, the cell-mediated immunity is zero. They tend to have more of humoral immunity, which is the antibody, and these antigen antibody complexes will then have type 3 hypersensitivity reactions. When we have a clinical feature, we will see that there is exacerbation of the existing lesion. We have exacerbation of the existing lesions. And the next, in lepromatous, you see new crops of lesions. They are usually these small nodules like erythema nodosum. Now, whatever is the type of reaction, whether type 1 and type 2, you will never stop giving multi-drug therapy. You will always continue giving multi-drug therapy. Even though MDT is the cause, you will never stop giving the multi-drug therapy. You will continue giving this because you want the M. lepra count to reduce with time. Second is you will add an anti-inflammatory drug, and the treatment of choice is actually corticosteroids. So the best possible answer which should be there, it is option number 3, continue MDT and add steroid. Steroid is considered to be a drug of choice for both type 1 and type 2. Whether a patient is a pregnant patient or she is non-pregnant, you have to give steroids and continue giving MDT. So that was the first question which we got in INI-CET. For more details, please keep subscribing this channel. The next question again, so in INI-CET we had two questions back to back from the chapter of leprosy. The question was, what is the treatment of a male with hypopigmented patch having thickened feeding nerve and the satellite lesion? This is a very easy question. Please remember what does WHO did. WHO have classified the leprosy patient into two groups. One is paucibacillary, means where the bacillary count is less, and another was multibacillary, where the bacterial count was more. How we had classified them? We have classified them on the number of lesion. If the skin lesion is 1 to 5 or with no nerve or single nerve involvement, it is these patients are considered to be a paucibacillary, while when the skin lesions are more than 5 with or without nerve, which is more than equals to 2, which is more than equals to 2, you will classify them multibacillary. For treating multibacillary and paucibacillary, for both of them, you use 3 drugs nowadays. There is no 2-drug therapy. You treat them by giving 3 drugs, that is rifampicin, clofazimine, and dapsone. The only difference is you have to give 6-month therapy or 6 packets for paucibacillary, and you have to give 12 packets of the same for multibacillary leprosy. That is the only difference. So 6-month and 12-month is the difference. Now, previously we used to have a different sort of treatment. We used to give 2 drugs for pauci. We used to give 3 drugs for multi, but we are not using this anymore. We are only using the red color kit, which includes 3 drugs. We are not using kit A, which was a 2-drug therapy for paucibacillary leprosy patients in the past. So kit B, but the patient was having a single nerve, so it is a paucibacillary patient. So kit B, 6-month therapy is the answer of choice. Okay. So kit B, 6 month is the answer of choice for this particular. Understood? Now, this is for your convenience. I have attached all the kits which is there for leprosy. Remember the color of the kit. The paucibacillary of adult and child is not used nowadays, but we use the adult kit for both pauci and multi, and the childhood kit for both pauci and multi. Try to remember this very important point. The next question. This was a relatively new question, and there are a lot of students who had no clue about this particular thing. Only those who have attended my plus or my face-to-face class, they might be knowing it, that what is a Kasowitz law and what is it related to. Kasowitz law is related to congenital syphilis. Now, congenital syphilis totally has 3 laws with it. The first law is Cooley's law. Cooley law says that the syphilitic infant transmit the disease to previously healthy wet nurses but never to their own mothers. And the reason of this is because their mother have some antibodies which can fight against the reinfection from the syphilitic infant. Well, what is the Kasowitz law? The Kasowitz law says that the untreated syphilitic mother tend to improve on her past performance. What is the reason? The reason is even if you do not treat a patient of pregnancy, the infectivity reduces with time. The rate of transmission reduces with time. And that is why the pregnancy outcomes in the future pregnancies always better than the past pregnancies. There is one more law which you might be knowing, Profeta's law, it says that congenital syphilitic baby is absolutely normal at the time of birth. It is very difficult to comment whether the baby is a positive case of congenital syphilis or not because he looks absolutely fine. You have to do investigations to prove whether he is a case of syphilis or not. So that is a Profeta law. So relatively new question. So all my INI-CET aspirants, I want you to just have a look on this particular feature. The next question, this is again something which I've seen a lot of time, frequent repeat. An old man presented with a polymorphic lesion on a dermatomal distribution. He complains of spider crawling sensation at night or during sleeping on the affected areas. You can see grouped vesicular lesions. Let me just zoom this for all of you. So grouped vesicular lesions on a single dermatome, very classical of herpes zoster, which is also known as shingles. Grouped vesicular lesions, herpes zoster. Now this was a question. There was some overlap. Let me just move it a little bit above. Yes. So this was a question of match the following, very interesting question, and I always show students the images of the different type of scales, very very important. Now please remember, if you have to match the different type of scales, you should know what are the different type of scales that exist. First thing is, what is a scale? Scale is nothing but retained layer of stratum corneum. There is a normal epidermal turnover. The stratum corneum has to fall after some time. But in few diseases, the stratum corneum remain retained, and that is known as scales. Please remember the micaceous silver scales or silvery micaceous scales is a very characteristic feature of psoriasis. This is for psoriasis. Yellow greasy scales, yellow greasy scales is for seborrheic dermatitis. Fishy scale is for ichthyosis. Fish-like scale, fish skin-like scales, and colored scale is for pityriasis rosea. So if you have to match it, pityriasis rosea has a colored scale, so one goes for D. Psoriasis, it has a silvery scale, so two goes for C. PLC has a Michael-like scale, so 3 goes for B, and Pityriasis versicolor has a very fine briny-like scales, so 4 goes for A, and the correct answer is A, G, 2C, 3B, and 4A. Understood everyone? So very simple question. Try to remember the different type of scales which you can get in your exams again. The next question was a little overlap questions, medicine dermatology. A young boy, 10-year-old, complains of arthritis, papules, rash as shown. What can be the diagnosis? Please remember, this is a very classical image of Gottron's papule, and Gottron's papule and plaque is the characteristic feature of dermatomyositis. In dermatomyositis patients, you develop Gottron's papules, swelling and erythema around the eyes, which is known as heliotrope rash, the fissuring of the palmar skin known as mechanic hand, confluent erythema of the upper back, which is known as Scholl sign, and all these cutaneous features associated with proximal muscle weakness. The next, this was one of the favorite question of year 2022 till now. A farmer with a history of what and a cauliflower lesion on the foot. What is the histology shows? Now these are the very classical copper penny bodies. Copper penny bodies. Very, very classical copper penny bodies, which is seen in the patients. Copper penny bodies. It's a very classical copper penny bodies, which is seen in the patients of chromoblastomycosis. They are known as sclerotic bodies, they are known as medullary bodies, and even copper penny bodies. So, all these names are given for the same conditions. We have seen that from the subcutaneous fungus, every year one question is for sure. So from this particular INI-CET 2022 dermatology, we got one idea that leprosy is one of the important topic. Second, STD. STD, since the beginning of INI-CET exam, that is a favorite topic. And third is infectious disorder. So without doing these three topics, do not think of going to the exams. Okay. So thank you all of you. I hope you have liked this session. Requesting all of you to please press the bell icon. Subscribe this YouTube channel, that is Dermatology Pearls by Dr. Cheshta. You can follow me on my Facebook page Dermatology Pearls by Dr. Cheshta and my Telegram group, that is Dermatology by Dr. Cheshta, for more updates. Thank you all of you and take care.